Welcome to the Weekly Neurology Deep Dive, produced by Amerigaminini. Today we're doing a deep dive into a really critical paper. It's comorbidities and their influence on outcomes and infectious complications in autoimmune encephalitis. That's by Bone and colleagues, published in Immunology Neuroinflammation in 2025. Okay, before we really get into it, just a quick heads up. This deep dive is purely educational. A summary of the research. We don't have any commercial goals here, and we definitely recommend you check out the full paper for all the details.
We picked this one because it really hits home on something crucial. That's recognizing and actually treating psychiatric issues alongside neurological disorders. There's often this stigma around mental health that can be a real barrier. But suggesting a psychiatric evaluation, it's not some kind of judgment of character at all. These disorders, they can affect anyone. Doesn't matter about intelligence, background, wealth. And they can develop even without an obvious history of emotional trauma. And crucially, acknowledging a psychiatric comorbidity doesn't mean the patient is somehow faking their neurological symptoms. Not at all. In fact, mental health challenges can often make those neurological symptoms feel, well, much more intense. So tackling both together, that can make a huge difference to outcomes, to quality of life. This paper gives you, as neurologists, solid evidence for that integrated approach. It provides the data to have those sometimes difficult conversations about mental health with your patients openly.
Absolutely. So for those of you maybe short on time today, let's give that practical summary up front. What are the key takeaways? Well, this study found psychiatric pre-existing conditions are a major independent risk factor for unfavorable outcomes in autoimmune encephalitis. We're talking increasing the odds by over 4.5 times. That's substantial. It also really highlights the high burden of comorbidities generally, especially other autoimmune conditions showing up more often than expected. And interestingly, while severe infections did happen during hospitalization, about 14% rate, they weren't actually linked to worse long-term outcomes. So the takeaway for your practice is really about heightened awareness of psychiatric comorbidities, needing an integrated approach, and, importantly, not holding back unnecessary immunomodulatory therapies due to infection fears. So with that framework, let's unpack how they actually did this study. What was the design?
It was a multicenter study, retrospective, using cohort data from the German Network for Research on Autoimmune Encephalitis. That's the GENERATE network. They looked specifically at adult patients with definite antibody-positive autoimmune encephalitis, focusing on 4 main types: anti-N-methyl D-aspartate receptor, anti-leucine-rich glioma inactivated 1, anti-contact and associated protein like 2, and anti-immunoglobulin-like cell adhesion molecule 5 autoimmune encephalitis.
Yeah, and how many patients were involved? What was the time frame? The cohort size was 308 patients in total. Broken down, that was 144 with anti-N-methyl D-aspartate receptor autoimmune encephalitis, 98 with anti-leucine-rich glioma inactivated 1, 47 with anti-contact and associated protein like 2, and 19 with anti-immunoglobulin-like cell adhesion molecule 5 autoimmune encephalitis. The data collection went from June 2004 all the way to July 2023. And importantly, they ensured at least 12 months of follow-up for assessing outcomes. They defined an unfavorable outcome pretty clearly, a modified Rankin scale score greater than 2 after that minimum 12-month period.
What really jumps out from that cohort is the sheer weight of comorbidities. Across all those subtypes, almost half, 49.7%, had cardiovascular and metabolic or endocrine pre-existing conditions. Around a third, 30.2%, had neurologic comorbidities already, and very notably, about 1/5, 21.1%, were affected by psychiatric comorbidities. Overall, 76%, so over 3/4 of patients, had at least one pre-existing condition, and more than a third, 37.3%, had 3 or more. It paints a picture of, well, a very complex patient group.
The general burden is high. You mentioned autoimmune comorbidities earlier. Let's circle back to that specifically. What did they find there?
That's a really interesting layer. Across the whole group, 12.7% had other autoimmune conditions, but it was particularly high in the anti-N-methyl D-aspartate receptor group, 14.6%. Now, compare that to the general population in that age group, 18 to 44. You'd expect maybe 4.1%, so it's much higher. For instance, multiple sclerosis was seen in 4.9% of these patients, the general population rate, only about 0.5%. And NMO spectrum disorder present in 0.7% here versus an estimated prevalence below 0.01% generally. Big differences.
Quite striking. Did this pattern of elevated autoimmune comorbidities hold true for the other subtypes they looked at?
It did, yes. For the anti-leucine-rich glioma inactivated 1 patients, 10.2% had autoimmune comorbidities. That included things like type 1 diabetes mellitus, found in 2.0% compared to maybe 0.5% in the older general population, 65 plus. And in the anti-contact and associated protein-like 2 group, it was 14.9% with autoimmune issues. For example, ulcerative colitis was seen in 4.3% of those cases. That's significantly higher than the estimated 0.7% for older adults. So seeing these autoimmune diseases cluster together like this really points towards, complex underlying factors, maybe shared genetic or environmental triggers.
Okay, so we have this picture of high comorbidity burden.
Yeah.
Now, the crucial part for practice. How did these conditions influence outcomes? What did the initial analysis show?
The first pass, the univariable analysis, flagged several things linked to worse outcomes. The anti-immunoglobulin-like cell adhesion molecule 5 subtype itself was a big one odds ratio of 4.95. Also, having a high modified Rankin scale score, meaning more severe disability at the peak of the illness, specifically a score over 2 that had an odds ratio of 3.01, and simply having 3 or more pre-existing conditions showed an association odds ratio 2.80. Drilling down into specific types of pre-existing conditions, cardiovascular ones had an odds ratio of 1.93, and psychiatric pre-existing conditions showed a really strong link, with an odds ratio of 3.84 in this initial look.
Those are some strong associations. But the key question is always independence, isn't it? When they controlled for other factors, what really stood out is driving unfavorable outcomes.
Exactly. That's what the multivariable regression aimed to uncover. And it confirms some expected factors. A high modified Rankin scale score greater than 2 at disease peak, basically. Worse initial severity remained an independent predictor. The anti-immunoglobulin-like cell adhesion molecule 5 subtype also remained independently linked to worse outcomes. And perhaps unsurprisingly, increasing age was also an independent risk factor. But here's the really critical finding. Those psychiatric pre-existing conditions. They emerged as a robust, independent predictor. The odds ratio was 4.55, with a p-value less than 0.01. This tells us that the impact of having a prior psychiatric condition goes well beyond just being linked to age or how sick the patient was initially. It's a factor in its own right.
That 4.55 odds ratio is really something. It implies that if a patient comes in with autoimmune encephalitis and has a history of psychiatric conditions, even if they seem stable, their risk of a poor long-term functional outcome is substantially higher, independent of other factors. Is that the right interpretation?
That's precisely the implication. It's not just an association. The analysis suggests it's an independent predictive factor for not recovering as well functionally down the line. It really underscores why understanding and addressing that psychiatric history is so critical from the outset. It's not separate from the neurological prognosis. It seems intrinsically linked.
Okay, shifting gears slightly. The study didn't just look at pre-existing conditions, but also secondary diagnoses that happened during the hospitalization. What came up there?
Right. They looked at complications during the acute phase. The anti-N-methyl-D aspartate receptor group actually had the highest rate here. 54.9% had at least one secondary diagnosis. Some specific findings included a systole in 4.9%, needing a pacemaker in 3.5%, and ovarian teratomas, which we know are linked, were found in 9.7% of that N-methyl-D aspartate receptor group. For the anti-leucine-rich glioma inactivated 1 patients, hyponatremia popped up in 22.5%, another known association.
And what about infections during that hospital stay? You mentioned earlier they occurred but weren't linked to outcome. Can you elaborate on the infection findings?
Certainly. Overall, 14.0% of patients had at least one infection during their hospital stay, and slightly less, 13.6%, experienced what were classified as severe infections, ones needing IVIG or invasive procedures. Hospital-acquired pneumonia was the most frequent infection, seen in 8.8% of all patients, but it was higher in the anti-N-methyl-D aspartate receptor group at 16.0%. Urinary tract infections were the next most common, at 5.5% overall.
Given that nearly 14% had severe infections and these patients often get strong immunosuppression, it's quite surprising they didn't impact the long-term modified Rankin scale score.
It is a very important finding for clinical decision-making, despite these infections occurring, and sometimes being severe. The analysis showed they were not associated with an unfavorable outcome later on. The p-value was 0.10 in the univariable look and 0.13 in the multivariable analysis. Not statistically significant. What did predict getting a severe infection? Well, the severity of the autoimmune encephalitis itself, measured by a high clinical assessment scale and autoimmune encephalitis score, specifically over 4 at peak that had an odds ratio of 5.41. And, as you might expect, being admitted to the intensive care unit was a massive predictor with an odds ratio of 20.76. Makes sense, sicker patients needing intensive care are more vulnerable, but the infection itself doesn't seem to independently drive the long-term functional outcome.
So let's synthesize all this. Bringing it back to the neurologist listening today, what are the absolute must-know clinical practice points from this deep dive?
Number one, absolutely, is the heightened awareness needed for comorbidities, especially psychiatric ones. That odds ratio of 4.55 for unfavorable outcome tied to psychiatric pre-existing conditions. That's a mandate to screen and address mental health proactively. This paper gives you the evidence to talk openly with patients about this, to try and overcome that stigma we mentioned. It's directly tied to their neurological prognosis.
Point two seems to be about the overlap with other autoimmune diseases.
Exactly. Seeing higher rates of conditions like multiple sclerosis or NMO spectrum disorder, particularly in the anti-N-methyl D aspartate receptor patients. It suggests you should maintain a degree of suspicion for these concurrent autoimmune disorders. There might be a shared underlying vulnerability.
And the third key point relates to treatment decisions, specifically around infections.
Precisely. The finding that severe infections, while not uncommon at 13.6% incidence, did not independently worsen long-term functional outcomes is crucial. It strongly supports the idea that you shouldn't withhold necessary aggressive immunomodulatory therapies purely out of fear of infection risk. Treating the underlying autoimmune encephalitis effectively and in a timely manner should remain the top priority. Taken together, the data really champions an integrated interdisciplinary approach with psychiatry playing a key role to truly optimize how these patients do long-term.
Excellent. Let's just quickly reiterate that practical summary one more time for everyone. This study clearly shows psychiatric pre-existing conditions are a powerful, independent risk factor, increasing the odds of a poor outcome in autoimmune encephalitis by more than 4.5 times. These patients carry a high burden of comorbidities overall, including significantly elevated rates of other autoimmune diseases. Importantly, severe infections during hospitalization, occurring in about 13.6%, did not predict worse long-term function. So, for your clinical practice, proactively screen for and manage psychiatric comorbidities using an integrated approach. This is vital. And don't let fear of infection stop you from using aggressive immunotherapy when it's indicated for the autoimmune encephalitis itself.
Which really leads us to a final thought, something provocative for you to consider. If integrating psychiatric care properly, early and robustly, can make such a profound difference in autoimmune encephalitis, what does that really imply for other complex neurological conditions? Conditions where mental health challenges are maybe common, but perhaps still overlooked or treated as secondary? How could we systemically embed this kind of integrated mental health care into routine neurological practice much more broadly?
That is a powerful question to reflect on. We strongly encourage you to read the full paper by Bone et al. To explore the data in even greater depth. Thank you for joining us on this weekly Neurology Deep Dive. We hope this discussion helps you feel more informed and ready to apply these important insights in your practice.